easily it's out. So this is open. We have a little bit.
Good. If I could invite the speakers to the podium, please.
He was
He picked it in about saying one more and he's still asking, but I was iffy. And that.
What is she saying? And I struggle with it.
Yeah.
both that and it was.
Oh, God.
So,
Okay.
and then you leave that. The what? The issue of that. Yeah, you could have correct. What she was saying.
Good. Welcome to the immunotherapy session. I am Hans Summers from Texas Southwestern, and with my colleague David McDermott from Beth Israel, we will be moderating this session. And David, would you like to introduce the first speaker?
Okay, our first speaker is well known to everyone here, Dr. Michael Atkins, who's Deputy Director of Georgetown-Lombardi Cancer Center. And he's here to talk to us about an overview and development of immunotherapy for kidney cancer. Mike, thank you very much for coming.
Thank you for the invitation and pleasure to lead off this session. These are my disclosures and potential conflicts. And this is an outline for my talk. And I'm going to go over my impression about where we stand with IO versus IO-TKI, add some more data to the favorable risk discussion that happened in the last session, talk about design of biomarker studies, some novel studies towards improved immune therapy, and then close with some novel immunotherapy agents. I like to start these talks now by just going back to basics about cancer immunotherapy principles. And Jed Walchuk said, and I think this is true, that when we give immune therapy, we're treating the immune system so that it can treat the cancer rather than directly targeting the tumor. And because the activated immune system can target many tumor antigens simultaneously and deepen and broaden over time, it can cure patients with metastatic cancer. And the hallmark, therefore, of effective immunotherapy are plateaus on the Kaplan-Meier curves, especially those that continue after treatment stops. And this is sort of second nature to the doctors who treat melanoma. They tend to look at the tail of the curves rather than the beginning of the curves, but it's not as commonplace or second nature in the kidney cancer field. And I think there's still a lot to learn in the way we use immune therapy in kidney cancer from melanoma. And one of the things that is now, I think, definitively shown is that blocking VEGF does not improve the overall immune response. And we've seen that in the LEAP-003 study in melanoma, where patients with metastatic melanoma were randomized to either len plus pembro versus placebo plus pembro. And we can see here that the purple curve, the placebo plus pembro, produce better overall survival. So TKIs are not immune therapy. And there's similar findings in the LEAP program in non-small cell lung cancer, head and neck cancer, and endometrial cancer. So it's not surprising when we look at these IO-TKI curves that we can see no tails in the three IO-TKI population compared to, see if I get this pointer right, compared to the Nivo-Ipi population where there's a tail. And we have to keep in mind that we're not comparing apples with oranges here, because the patients who have just gotten IO can also still get TKI and still get the maximum benefit from the TKI or a HIF-2 alpha inhibitor. And therefore, considering that, it's also not surprising that the overall survival curves are converging for those IO-TKI studies. And in contrast, and you can see here on these hazard ratios over time, the IO-TKI studies show up trending of those hazard ratios towards 1, while Nivo-Ipi is pretty flat, including all the way out now to 8 years in the recent updates. So what to do with the favorable risk population? Well, the reason why we can't give where we couldn't give Nivo-Ipi to the favorable risk population is because of these initial hazard ratios in the 214 study. But over time, with the 8-year follow-up, those curves have crossed, and we now see a survival benefit emerging for immune therapy, which I'm pleased to say has led to ESMO and NCCN changing their guidelines. But I want to go a little bit deeper than Tom went in his discussion, because in the HCRN trial where we just gave Nivo monotherapy, we saw that there was only 3% of favorable risk patients who had died at 3 years, while in the 214 study, there was 25% mortality at 3 years. So we were wondering, what did these patients in Checkmate 214 die from? Why weren't they salvaged with other therapies? And are these data still relevant in 2024? And in the poster that was there yesterday and in reviewing this data, we can see that 41% of the deaths in the favorable risk patients occurred in the first 3 years, and that 44% of those patients who were assigned to have progressive disease never received a subsequent TKI, while only 8% of the patients on sunitinib who progressed didn't receive subsequent therapy. And beyond 3 years, only 5% of the patients who progressed on Nivo-Ipi didn't receive subsequent therapy. And so if you want to look at this, this is a hazard functions curve which show the risk of dying at any particular time for the two therapies, immune therapy in red, sunitinib in black. And you can see, first of all, that the difference between immune therapy and targeted therapy is not that great in the early part, but the curves cross at 2 years, showing its non-proportional hazard. And over the subsequent period of time, you do much better on immune therapy. But I would say, that if these patients had received TKIs, that red line would be below the black line. And I think in 2024, now that we know how to better use immune therapy than we did previously, all those patients would receive TKIs. So I think this is our emerging understanding, at least my view in kidney cancer, is it's time to concede that IO-TKI combinations are not in the long-term best interest of the majority of our patients. And if we want to improve cure rates for patients with metastatic clear cell kidney cancer, we need to build on pure IO backbones. And it's also time to concede that the IMDC category should not inform immunotherapy treatment recommendations for patients with advanced kidney cancer. And we should include favorable risk patients in all of our immunotherapy trials and report ITT endpoints only. And I think the ESMO and NCCN guidelines should remove those separations based on IMDC risk altogether. So how do we move forward from here? I think predictive biomarkers for IO therapy, and when doing so, we should focus on metastatic lesions in treatment-naive patients using pure IO regimens. We should focus on IO endpoints when we're looking at those biomarkers such as landmark PFS, overall survival, durable response, and treatment-free survival. And we should develop regimens that overcome IO resistance mechanisms. So Tom showed this slide this is from the cluster data in Emotion 151, and you can see that the IMDC categories represent a lot of different RNA-seq clusters. And recognizing this, Brian Rinne and his group has developed the OPTIC trial, which is going to choose therapy based on clusters, those in cluster 1 and 2 getting IO TKIs, those in cluster 4 and 5 getting IO. However, if we look at our HCRN data and look at the cluster analysis, we can see that cluster 4 does enrich for response to immune therapy, but there was plenty of activity with just anti-PD-1 in cluster 1 and in cluster 3 and in cluster 6. And so I think although that study may be interesting, it might not be fully addressing what is the best therapy for those individuals. It's just assuming what the best therapy is. And further, if we look at the relationship between cluster in primary tumors and metastatic disease from the HCRN trial, we see that there's no strong correlation between cluster type in the primary and the MET, and that METs tend to be less angiogenic than their primary. So I'm going to go out on a limb and say because of this data, I think neoadjuvant studies, in contrast to melanoma or lung cancer, are going to be less informative in kidney cancer, and also doing vaccine trials that are based purely on neoantigens developed from the primary tumors are going to also be less important than if we did them from the metastatic sites. So what about promising studies based on biomarkers? Well, we've published data looking at things associated with response and things associated with resistance, and the ones in black here actually came from our DOD grad with Kathy Wu and David Braun. I'm not going to talk about those. Maybe David will talk about them. But the two in red I will talk about, and we saw in work done by Sabina Sigureti that patients whose tumors have high CD8, PD1 positive tumors, positive T cells in their tumors that lack TIM3 or LAG3 do better than those that have CD8 positive PD1 positive cells that have LAG3 or TIM3 on them. And so this, I think, is justification for studying anti-LAG3, anti-PD1 plus or minus CTLA4 in the front line in patients with kidney cancer. And there are two trials going on, one in the KCRS consortium that will soon open, and another in HCRN that is being written. This is the design of the HCRN trial that Katie Beckerman is leading, looking at fianlimab plus cemiplimab plus or minus ipilimumab with nivo-ipi as a control backbone. In addition, as was mentioned yesterday by Mike Surzan, patients who have PD-1 on their Tregs tend to do worse, and it's this balance between PD-1 on Tregs versus PD-1 on your CD8s that may be important in what happens when you give an anti-PD-1 regimen, which gives a justification for giving agents that potentially deplete Tregs, such as botensilimab, which showed all this activity in MSS colon cancer with 17% response rate, which led to the ARCHITECT trial, which you've heard about already, except to say that Sabina Sigureti, David Braun, and myself now have a DOD-supported team science grant to do the correlatives for this particular trial. So here's some other promising immunotherapy approaches that you've heard about already or may hear about in the rest of the session. And as you're listening to them, I want you to keep in mind that our goal should not be to simply turn cancer into a chronic disease. We should strive to make cancer a curable disease. That's what our patients want. And in order to do that, I think using agents in combinations as first-line treatment that maximize the anti-tumor immune response is critical to achieving that goal. And I'll close by just thanking all my colleagues who helped with this work and my funding sources. Thank you very much.
Any questions? Comments?
So that's definitive then, I guess.
Good. Let's move on with our next speaker, and Dr. Rizwan Romee from the Dana-Farber. With mechanism and predictors of adaptive cytokine-induced memory like NK cell therapy and neosarcoma. Thank you so much.
Thanks for the introduction. I kind of changed the title on purpose, and I'll explain why I changed what is written on the brochure. So I do NK cells, and that's my first love. My wife even thinks that's my main love in life. So why do we care about natural killer cells when the T cells have taken over the world? Well, there are several advantages of using NK cells, both for adaptive immunotherapy as well as coming with ways or novel approaches to activate them in vivo. First of all, they don't have the risk of causing severe CRS or cytokine release syndrome, which across the board with different T-cell-based therapies has been observed, including some fatalities. There's no risk of graft versus host disease if you were to go for an allogenic product. So a lot of interest in developing off-the-shelf products these days. But then if you are going with a T-cell product, then you have to abrogate the expression of TCR. Otherwise, you are running the risk of causing graft versus host disease, where the adoptive transfer allergic T cells will potentially recognize some of the minor or major histocompatibility antigens in the host. They have intrinsic ability to target tumors through NKG2D ligands. For example, MICA and MICB and other stress ligands are well known to be expressed in increased density by different tumor cells, and NK cells possess this basic ability to target tumor cells, recognizing these stress ligands, and that's the name why we call them natural killer cells, or naturally born killer cells. They express CD16. Most of the NK cells express CD16, which is the receptor for Fc domain of IgG1. There have been some exciting developments with the new Fc-enhanced antibodies against CTLA-4, for example, recently. But then other antibodies have a well-known ADCC function where tumor cells get coated with those antibodies, and then you attack them with the CD16, which is expressed by NK cells and monocytes. There is a separate version of CD16 expressed for neutrophils, but that's not for ADC. That's a different gene. Then if they have all these good properties, why haven't we really seen multiple NK cell-based products approved until now? I think the biggest challenge in the field, in the NK cell field, has been the fact that the NK cell, their half-life is only 10 to 12 days. So in any cellular therapy product, if you want to create a successful, durable, therapy product, it better have half-life of more than few weeks. Having few days is not enough, because then you run into the problem of needing to give every few weeks, and then also if you were to give every few weeks, lymphodepletion, which is something which we haven't really overcome since the days Dr. Steven Rosenberg started TIL therapy back in 1978, around the time I was born. So then how do you overcome this major challenge in the field that their half-life is only 10 to 12 days? Long time back, when I was a postdoc at Washington University, we got interested in trying to figure out whether NK cells under different circumstances will remember their activation. So this is a relatively new concept called innate memory. If you Google or if you PubMed innate memory, you'll see several papers, recent papers, where different innate lymphocytes, including macrophages, including more recently hematopoietic stem cells, can remember their activation signal or some signal which then it's mostly epigenetically mediated, they remember for the rest of their lives. Back in 2010-12, when we were working on this was a relatively new concept. There was some mouse data that could happen, but it was relatively hard for us to even publish that if you were to activate conventional NK cells, there is certain cytokines trying to mimic what is happening in an inflamed lymph node. They remember that activation for the rest of their lives. So there's epigenetic reprogramming, and we call them cytokine-induced memory like NK cells because we use cytokines to activate them. More recently, there's also data that certain infections, for example, tuberculosis can do a similar phenomenon in certain subsets of NK cells. But nonetheless, in this work, we showed that activation of conventional NK cells with a cytokine cocktail, including IL-12 and 18, 15 was just as a survival signal, leads to activation. But then when you rest those NK cells next day, they differentiate into these memory-like NK cells, and they mediate enhanced interferon gamma response as shown in this figure upon tube-1 engagement or the stimulation of the cytokines. But then more interestingly, we found that these memory-like NK cells or the cytokine-induced memory-like NK cells live up to 60 to 90 days in a syngeneic mouse model. And more recently, we have shown that even in a patient setting, in a clinical trial setting, they can live up to 8 months. So that's a big boost to the field, in my opinion, because as I said, the biggest challenge in the NK cell field has been the short half-life of NK cells. In addition to these interesting properties, they also have low TGF-beta receptor expression, so they're relatively resistant to TGF-beta mediated inhibition, and they are also they have increased metabolic fitness. We actually did a first-in-human trial at WashU, where I was faculty before moving to Dana-Farber in 2017-18, where we took patients with relapsed refractory acute myeloid leukemia and MDS and infused family member-derived these memory-like NK cells. And we were pleasantly surprised to see around 50%, exactly 46% CR rate in patients who otherwise had really gone through a lot of chemotherapy and had no meaningful chance of getting into remission. Then I moved to Dana-Farber, and we have a full NK cell program, and we have around 6 trials currently, including the one which is funded partly by KidneyCAN Cancer and in collaboration with Tony and Vincent. So my lab has been really hard at developing CARs using these memory-like NK cells, and I have taken interest of using IL-12 engineering into these memory-like NK cell CARs. Now, why IL-12? Every time you hear IL-12 in a T cell CAR, they get immediately, no, bad idea, because people have died with IL-12 in T cell world. But turns out the secretome of CAR NK cells, as shown here on the left side, versus the CAR T cells from the same donor is dramatically different. So when you take CAR NK cells or CAR T cells, same target, same everything, you put with tumor, co-culture, and then you take the secretome by doing multiplex or ELISA for different molecules, you have to 96 markers, and we found very dramatic differences, including some of the things like IL-2, IL-6, GM-CSF. So bottom line is CAR NK cells, very benign, and people have shown in multiple trials now they don't cause CRS, CAR T cells very toxic. And because of this, it gave us encouragement to use IL-12 engineering. So how else to make IL-12 safe? We engineered the IL-12 and incorporate A3 domain from von Willebrand factor as shown here on the right side. So von Willebrand factor is a large molecule. A3 domain helps it bind to the subendothelial collagen. Turns out many cancers, including kidney cancer, have high expression of collagen 1 and 3. And this is what it binds. So we create this fusion protein IL-12 secreted by our CAR, and it has the collagen binding domains that gets trapped into the tumor microenvironment. We tested these IL-12 engineered CARs against different targets, and this is some of the killing data as well, interferon gamma data. So very dramatic interferon gamma response shown in the left upper side. Against this is the pancreatic cancer and ovarian cancer. On the right side is the pancreatic cancer organoids, patient-derived. As you can see, this is mesothelin. The top one is the mesothelin. As you can see, very dramatic enhancement. And then left lower side is CD70. As you know, CD70 is highly expressed on kidney cancer. Recent data, including from our friend Monty Pauls, and his group has shown it's a potential target. So we tested our CAR, and again, we see dramatic responses against the CD70 expressing cell line. And then in vivo, we created a model where we injected ovarian cancer and infused these cells. And then not only we cured these mice with a sub-therapeutic dose, which I have never seen in in my career that NK cells using only less than 1 million cells per mouse led to cures in so many of these mice as shown in this survival curve. But more importantly, when we took the blood from different time points, we saw if the IL-12 had that A3 domain from one factor, there was no or very little systemic exposure. So we are very excited about it. We are hoping to take it to clinic. Last few slides, is CAR the best way to deliver cytokines, in our case, IL-12? So more recently, there's more and more interest in using bacteria for as a biotherapeutic modality. We asked, can we modify E. coli, non-pathogenic strain of E. coli, to express different cytokines? And we did a whole screen. So first of all, we took E. coli, this particular strain called K12DH5. And why K12DH5? It's tumor tropic, that's well known. It's facultative anaerobe, so many solid tumors are hypoxemic. It's safe as no toxin islands. And why surface? Why not discrete it? Because surface display allows longer half-life, higher effective concentration, and then the fact that bacteria on their own have this adjuvant effect through TLR agonism. So we did then the whole screen of different cytokines as shown on the left floor. These numbers are kind of complex, but these are different scaffolds, different cytokines, showing the expression. I'm not showing you that, but then in vivo, and this is the MC36, which is colorectal carcinoma, intratumoral injection, and looked at the shrinkage, and one particular combination, this E. coli expressing decoy-resistant IL-18 with this particular scaffold caused the maximum shrinkage of the tumor. But then we did a more formal, so further work was done using this particular combination. As shown at the top, this is the schema. These are the syngenic mouse model. Using MC38, we have similar data for B16. I'm not showing here. So we kept giving, this is all intratumoral, actually intratumoral, 3 injections. Why 3 injections? Because after third, we couldn't detect any tumors in any of those mice. And then we let them chill, and half the mice never recurred, which was pretty interesting. We also did recall, meaning this with is mice which had been cured of the tumors we re-injected, and saw none of those mice had any tumor recurrence. Since then, we have done actually in vivo, systemic delivery as well. And this is the data in combination and alone with PD-1 blockade. So what was surprising that these bacteria were able to beat PD-1 blockade in this MC38 model as shown here. So, and not only that, they beat them, but also in synergy, we have seen the best curative responses. And this is an example at the bottom, the mouse which received this bacteria clearing the tumor. And we have now several mice which have received PD-1 plus our bacteria, and they are more than 100 days, and we don't know what to do with them. Hopefully, we'll have some further experimental plans with them. But the point I'm trying to make is that this is a very, very effective constant combination of PD-1 blockade and our genetically modified bacteria. And this is safe both intratumorally as well as systemic, and we are keen to take to clinic. I would like to thank my lab members who did most of the work, as well as my collaborators, including Tony, Vincent, and David, who are all here.
Beautiful work. Questions?
Each question right here. Jeff has a question.
Microphone is a micro.
Yeah, the bacterial engineering.
Good catch, by the way.
Yes, the bacterial engineering is really interesting. But what's the half-life of the bacteria when they get into the tumor? Because I can see that would be the IL-18 could boost things, but the bacteria on their own should be immunogenic, inflammatory.
Absolutely.
But they also could be cleared very fast. So
hopefully the paper will come out, all of that's included in this. I didn't show everything. So when we did the intratumoral injection, we found that the bacteria lasted in the tumors for around 10 to 12 days. After 12 days, they were gone. And then when we did the systemic IV injection, the same bacteria, first of all, they preferred around 10,000-fold higher infiltration or a concentration in the tumors versus some concentration or some infiltration in the kidneys and liver. But then within 2 or 3 days, those were cleared from the liver and kidneys, no other organs, but the tumors up to 7 days. And on its own, without the IL-18, we saw similar trafficking and similar survival, if you will. But then the tumor control, there was some tumor control on its own, but it was not nearly as robust as when they had IL-18 on them.
And if you give a subsequent, you gave 3 injections of these bacteria, but how fast are they turned over after the second and third injections? Because you can be priming the immune system to be eliminating these bacteria faster.
Yeah. So we did, and we found that actually when the reviewers asked this question, and we actually did we looked at the lymph nodes, the draining lymph nodes, where we looked at the B cells and plasma cells. There was increase in the B cells, but when the depletion of the plasma cells and B cells by antibody, it didn't seem to affect the immune response. Now, number one, so that gave us confidence that this is more durable. And then the very challenge really helped kind of solidify that actually this, whatever immune system, whatever immune response was generated was durable and probably independent of the bacteria surviving for long term. But in terms of the kinetics, after second injection, the reason we give only 3 injections is not we couldn't give more, but there was nothing to inject. So all of these mice, invariably, both B16 and MC30, that was kind of dramatic. When your student comes to you, say that, I don't know what to inject now because after second injection, there is nothing left. So I didn't believe it. And then I actually saw those mice. It's very, very dramatic response. And there is initial some necrosis, and there is also some granulocytic infiltration. But then we did the granulocyte removal or the depletion, and that did not impact the positive response. So very dramatic, very quick for the intratumoral. But systemic, it's a little bit less subtle, but nonetheless, the combination of the anti-PD-1, again, 7 out of 10 mice were cured out of more than 100 days out.
Great, thank you.
Abhishek has a question.
So my question is about, if I understood correctly, you're ex vivo treating the NK cells, and you're having some sort of activation memory when you're injecting the NK cells. Do you have any ideas about what is the actual reprogramming that happened in the NK cells?
So there have been multiple papers on this, and including some of our group. So we see a lot of epigenetic reprogramming. Some of the key things are the enhancer element around the interferon gamma locus, for example, is open after this. But then there's also metabolic reprogramming. So they're really good at OXPHOS, for example, very robust. And then several other changes. But yes, there's multiple changes happening.
And so the reason why I'm bringing this up is because I think a lot of the validation work right now that you have done is, I think, in the mouse syngeneic lines. As we move along, probably testing and validating human lines, maybe allogenic we activate the human NK cells and try to test those out. Do you think the underlying physiology of the mouse and the human NK?
This is a great question. So we have published now 3 trials. There's a science transformation, another science transformation, and a cancer discovery, and a JCI using the same models in humans. And we have validated that. Absolutely, but great question.
Well, Czar needs the ball.
On the ball. I thought. A little bit tense. You have to catch the ball. There we go. Okay, no question then.
It was not a good path.
Okay, yeah, it was about 15 minutes.
Great talk, but
thank you.
This is a general question. I don't see a counterpart presentation in this session about CAR T, but just a general about cellular therapy, clinically. Okay, why do you think? What are the challenges in producing durable responses in solid tumors in cellular therapy? I mean, compared to hematological, we have several FDA-approved cellular therapies.
Yeah.
CAR T and CAR NK, and obviously from MD Anderson, Katie Rizvani's work, sure colleague, moving the field forward with the CAR T. What do you think is the challenge here with seeing durable response to solid tumors?
I think, first of all, we got lucky with the initial work with CD19 or CD20 and BCMA. Those are the molecules, they are kind of Achilles heel, if you will, on the especially CD19 and more recently CD22 on B cells. So you can kill them, cells die. They don't, even there, we are talking about only 40 to 50% CR cure rates. We are not talking about 100%. Even there is immune escape eventually in most of the patients. And the multiple myeloma, which is the next kind of where the CAR T cells have been approved, so far we haven't had a curative therapy because plateaus haven't been achieved. So speaking volumes about even in the best case scenario, which is hematologic malignancy, we haven't really conquered the world. And so that's something to keep in mind. But then the big elephant in the room, what about the solid tumors? We haven't really had a huge success other than some stable disease, some PRs, but not durability. I think solid tumors, first, one antigen is not enough. Targeting one is never enough in solid tumors. There's more heterogeneity and more mutations, and cells are more and difficult to treat, meaning tumor cells. The tumor microenvironment itself is so immune suppressive. Forget about killing the cells themselves. Many times they don't even get into the tumors before they can actually do something. So that was part of the reason actually we decided to use bacteria, because we found bacteria can actually, in the hopefully upcoming paper, we've stained the tumors and very nicely infiltrating into the tumor, very diffusely infiltrating into the tumor. So there need to be smart ways of delivering potent molecules, be it PD-1 blockade, be it next generation CTLA-4, that they need to reach the target, which the tumor microenvironment, then inhibit the inhibitory pathways, so TGF-beta, the IDO pathway, the prostaglandin pathway. There's so many pathways. So it's complex. The tumor microenvironment is so complex. Getting in there, not getting suppressed, recognizing tumors, I think they are the three major challenges in addition to the lifespan of the CAR-T or CAR-NK itself.
So, Riz, excellent talk. Excellent answer. That answer could have been a second talk.
Sorry.
No, it's good.
I'm passionate about.
No, it's good. And we feel your energy. It's awesome, but we need to move on. Thank you very much.
Thank you.
Our next speaker is from the strong UT Southwestern Medical Center team in kidney cancer. Srinivas Malladi is going to talk to us about to delineate a tumor-immune contexture that shapes clear cell RCC metastatic progression and response to immunotherapy. Srinivas, thank you very much for coming.
Thank you. Thank you for the kind invitation to present here and the opportunity itself, and also the support from DoD for our research. So I'm a molecular biologist in this program, so I'm learning a lot in terms of over what happens in clinic. So this is more of a basic talk in terms of what we do in the lab. So my lab at Southwestern is basically focused on understanding the biology of disseminated tumor cells with metastatic potential. As you know, majority of the cancer-related deaths are caused by metastasis, and treating metastasis still remains a challenge. So in order to be metastatic, cancer cell within the primary tumor needs to invade, intravasate, survive in circulation, successfully extravasate, then set up a second shop at the distal organ, and then again adapt to the new microenvironment, and then initiate secondary tumors or metastasis. So it's a very inefficient process in which close to 90% or 99% of the cells that leave the primary tumors don't make it, and the very few that persist give rise to overt metastasis. And current therapeutic options, including immunotherapy, seem to be less effective on metastatic lesions. So moreover, we also know that all invasive tumors don't metastasize, and not all metastatic tumors can also currently been effectively treated. So in the lab, we are more focused on understanding the biology of this whole metastatic process, trying to identify the cellular and molecular mechanisms that promote metastases, and hopefully identify strategies so that we can eradicate these cells with metastatic potential. So towards this goal, we exploited a very unique feature that is found in CCRC tumors, where in approximately 15% of CCRC tumors, you see this invasion of tumors into the renal veil, and they extend as tumor thrombus. So these tumors have very clearly defined invasive fronts, and these are more likely to be the sites for metastatic dissemination when compared to non-invasive tumors. So we did a spatial analysis on this one. So we collected several multi-region samples on this along the primary tumor and also along the invasive front. Performed a lot of analysis in terms of whole exome sequencing, transcriptomics, and histologically to see if we can identify traits that would make these tumors more invasive and metastatic. So when we look at histological profiles, we do find both indolent and aggressive patterns, as Powell mentioned yesterday, although the aggressive pattern seems to be more associated with the invasive front within the tumor thrombus. When we looked at the exome sequences, clearly we could not find very significant differences that would separate invasive and non-invasive tumors. Tumors with diverse oncogenomic status were able to invade. Not much significant difference in terms of mutational burden, number of driver mutations, or enrichment for driver mutations in metastatic tumors or invasive tumors when compared to that of non-invasive tumors. Transcriptomically, there were differences, but the major significant difference was enrichment of immediate early genes within the tumor thrombus, which was at the very invasive front of these ones. So we have clinical follow-up of these patients for over a decade now at UT Southwestern. So when we looked at the tumors that were invasive, this tumor trauma, only 50% of these patients developed metastasis or had disease recurrence. So it's very important to note that not all invasive tumors are metastatic. So this gave us an opportunity to separate these invasive tumors into metastatic and non-metastatic tumors. So when we did that, we re-performed the analysis to see if we could now find any differences in any driver mutations or copy number alterations that would separate these tumors, which we did not see. So, and when we looked at the pathological analysis of this, one thing that stood out very strongly was the grade of the tumor thrombus that Powell mentioned yesterday. So the grade of the invasive front does matter, and if the tumors of same grade have higher grade in the invasive front, they are more metastatic, and it was gratifying to see these results kind of reproducibly seen in a large patient cohort of 600 invasive tumor thrombosis. So since we have separated these tumors into metastatic and non-metastatic cohort, we further explored the transcriptomic data and were able to develop a metastasis prognostic kind of signature with 70 genes that were upregulated in these metastatic invasive tumors, which had bad prognosis in CCRCCs and other RCC types, and 61 of these genes had lower expression, which were good prognosis genes in these patient cohorts. We also performed gene set enrichment analysis and gene ontology analysis on this. And one of the things that was quite strikingly coming up was enriched inflammatory responses and immune cell signaling responses in metastatic tumors. So we checked to see if these expression of this immunoinflammatory genes and immune infiltrating genes would alter the stromal composition of these metastatic tumors. So for this, we took a computational approach and we performed a tumor-immune microenvironment resource estimation where you can estimate the microenvironment of these tumors based on RNA sequencing data. And when we look at this, we do find a significant enrichment in regulatory T cells, monocytes, and macrophages in these metastatic tumors when compared to that of the non-metastatic tumors. We see a decrease in CD4 T cells, dendritic cells, and K cells in metastatic tumors. So we validated some of these findings by performing IHC analysis. And here I'm showing you where in the metastatic tumors you do see increased expression of macrophages, which are of the M2 subtype. We also looked to see if there was any difference in PD-L1 expression in these metastatic and non-metastatic cohorts, and we did not see much difference in there. So now, to perform functional studies and to better assess, define the mechanisms that promote metastasis, we are developing PDXs and PDX organoids from these non-metastatic tumors and metastatic tumors. So here I'm showing you a few examples of these non-metastatic tumors and metastatic tumor PDX organoids. So we already see they are quite heterogeneous in terms of both their morphology and growth rates. We find most of the non-metastatic PDX organoids to be more sporadical with the compressing of lumen, whereas the metastatic organoid seems to be quite invasive or branched, and even in terms of their growth, they seem to be quite different. So now we are implanting these organoids into mice to further assess their metastatic incidence and burden in lungs and liver. So we hope to isolate and generate metastatic organoids from this and perform transcriptomic and metabolic analysis to see if we can identify new targets or new ways to limit metastasis in these models. And as I mentioned earlier, we also had seen that the tumor microenvironment and the infiltrating immune cells do play a role in dissemination of these cells, and they were enriched in metastatic models. So we resorted to model this by using humanized models. I do realize they are not perfect and they come with a lot of limitations, but they're definitely better than just NSG mice. So now we have optimized protocols to humanize mice and using CD34 hematopoietic stem cells from cord blood. And we see around 10 weeks after CD34 transplantation, mice are pretty well humanized. We see around 70% of the CD45 cells in the mice to be more human. And of these CD45 cells, we are seeing good representation of T cells, myeloid cells, NK cells, and B cells in this population, anywhere from 10 weeks to 17 to 18 weeks post CD34 transplantation. So this gives us enough time to implant these organoids or PDXs in these mice and assess their impact. So we started doing these experiments. These are very preliminary, and we can already see, like, between non-humanized and humanized mice, these are metastatic tumors. When we implant them, differences in their growth rates. In the non-humanized mice, we are seeing tumors grow up pretty fast. There is a lag phase in the tumors that were implanted in these humanized models. So now we are going to assess the tumor cell profiles in these two different backgrounds, metastatic incidence and burden. And we also are aiming to perform single cell and or spatial analysis between tumors from non-metastatic and metastatic ones in these backgrounds to see if we can identify any differences, and also test response to therapies, including immunotherapy if we can. So with that, I would like to thank the people in my lab who have done most of the work, Kang Sang, Shuhei, and Tuen. And also would like to thank the UT Southwestern Kidney Cancer Support Program for providing us with a lot of resources and good discussion, and my colleague and neighbor Cheng for all the discussions we have on this in the funding research. Thank you.
And questions? I had a question. With this invasive pattern that you showed in these spheroidal structures that you're generating, these organoids, are there certain programs that you think about that are important for those? And then could those programs predict recurrence or progression, metastatic progression?
That's what we are looking. So even within from the same patient, when we get these different organoids, there is heterogeneity in them. So we are trying to now get these organoids which are invasive and separate them out. Those features seem to be stable. We thought they could be stochastic and we could see again a range. So now we are trying to implant them separately to see if they are a better prediction of metastasis.
Hey, Srini, great work as always. Just a quick question for the humanized model when you're doing the implantation. Is that orthotopic or subcutaneous, and have you compared the two?
Orthotopic.
Okay.
Yeah.
Yeah, just from the work that we've done, we've seen clearly different immune infiltration patterns and immunocompetent systems, whether they're subcutaneous or orthotopic. So I encourage you to continue that. That's great.
Thank you.
We have a burning question, so let's move on to our next speaker. Okay, Jonathan Powell from Calico. Biologist from Hopkins original.
Great. Thank you very much for the opportunity for me to tell you about a novel target and our novel drug ABV CLS484, which is currently in phase 1 trials, and we're hoping to expand and do our expansions particularly in renal cell. And the one thing that I want to emphasize is the immunotherapy has really been dominated by thousands of combinations of checkpoint inhibitors. And so we're really excited because this is not a checkpoint inhibitor. It's really a novel mechanism of action in terms of immunotherapy. And for those of you in the Boston area, you're probably familiar a little bit with the history of it, is that Rob Manguso, who is in Nick Caney's lab, did a CRISPR screen of tumors and found that knocking out P2PN2, which is a phosphatase in the tumor itself, made the tumor susceptible to killing by the immune system through enhanced interferon gamma signaling. So tumor intrinsic mechanism. Almost simultaneously, Arlene Sharp's lab actually was doing a CRISPR scene in T cells and found that if you knock out eliminate P2N2 in T cells, you get this enhanced immune activation effect. So the really cool thing about targeting P2N2 is you're targeting both the tumor intrinsic mechanism as well as the immune system itself. So recently, actually, the team, both from the Broad, led by Rob Manguso, and from AbbVie, our collaborators in terms of drug development, recently published this paper in Nature about this specific molecule, 484. And it really was a tour de force from both the biology perspective and the medchem perspective, in that it used to be thought that phosphatases were really hard to drug. And on the bottom of the slide, what I really want to emphasize is that whereas this drug activates the immune system, just like, for example, checkpoint blockade, it does so with a different pattern. So it's not just adding on the same old thing when you do combination therapy, but has the potential to be really synergistic. So this is just like typical data in terms of the syngeneic models. You can see that our initial focus is in IO-sensitive tumors, and indeed, at least in the syngeneic models, P2N2 inhibitor 484 is able to be incredibly potent in those models, just as potent, if not better, than anti-PD-1. It can synergize with anti-PD-1. And in the bottom, which is the 421 breast cancer model, you can see that in this case, for those of you who've done this, you know that 421 is pretty resistant to anti-PD-1, yet we get a better effect with P2N2. So tons of data in mice showing that, this has great potential. And again, being different than the checkpoint inhibitors. I realize in humans, there's controversy in terms of whether to put IO and TKI together. But in mice, there's no controversy. It seems to work. And indeed, when we combine P2BN2 inhibitor with, and on the top is lenvatinib, on the bottom is Cabo, in various syngeneic models, we get really nice synergy, where you see each of the drugs alone don't work as well, but when you put them together, you get a nice effect. So again, it's only in mice, but at least it gives us a hint that maybe this would be a good combination together in humans. So now I'm going to actually show you some data from my own lab in that Yu Lu in my lab is really interested in the potential effect of P2N2 inhibition in preventing metastasis. Because, for example, in those 421 models, the tumors eventually grow, yet the mice are running around the cage. And the reason they didn't look sick when the primary tumor was growing is because they really didn't have any mets to the lung. And so what Yu was able to show in kind of a nice experiment is when she knocked out P2N2 in the tumor, you still got metastasis. But if you gave the drug, you were able to prevent metastasis. And then we have a lot of data. I'm not going to be able to show you that the way this works is by altering actually the metastatic niche. So within the lung, preventing myeloid-derived suppressor cells, neutrophils from accumulating and allowing the tumor cells to take hold. So again, we're excited by this data because we think that this suggests that P2N2 inhibition may be good in the adjuvant setting as well. In addition, CAR T cells have been touched upon a little bit. It's also been mentioned that, in the heme malignancy setting, they seem to work really well, but not so much yet in the solid tumors. And so on the left, I'm showing you a figure from Marcela Maas's paper. I think it's a beautiful paper where she really addresses that question head on. And one of the conclusions she came to is that due to a lack of interferon gamma signaling within the solid tumors, that's one of the reasons why they're more resistant than the hematologic malignancies, which have the upregulation of certain ligands, even in the absence of gamma interferon. And so I told you that our drug P2N2 inhibitor actually leads to the upregulation of signaling in response to gamma interferon. So, and that's shown on the right. So our hypothesis is that we could condition solid tumors to be more susceptible to CAR T cell therapy. And indeed, again, just a snippet of the data, we actually have a lot of data on this. This is just showing you in a contrived mouse model, B16 expressing CD19 using mouse CD19 CAR system that when we give the mice P2N2 inhibitor, that we can markedly enhance the efficacy of the CAR T cells. And what I'm not showing you here, but the data is actually really cool as well, is that, again, because inhibiting P2BN2 enhances the T cell response as well, we have really dramatic effects on the CAR T cells themselves in terms of both homeostatic proliferation, persistence, changing their metabolism such that they persist longer, and then actually enhancing their ability to kill tumors. So in keeping on time, just in summary, we have our drug ABV-CLS-484 is a PTPN2 phosphatase inhibitor, and it has a very distinct mechanism from current checkpoint therapies, acting both on the tumor and the immune system. It synergizes with checkpoint inhibitors as well as, at least in mice, VEGF TKI. We're really excited about this data in terms of preventing metastasis by changing the metastatic niche, as well as enhancing CAR T cell therapy and really maybe being an adjuvant to CAR T cells to really enhance their ability to be more successful in the solid tumor setting. And, as I mentioned, I didn't really talk about the trial today, but our drug is currently in phase 1B clinical trial. That's the ct.gov number. And it's kind of cool. It's been a little bit difficult figuring out exactly how to deploy this drug because there really are no small molecule inhibitors that are IO drugs. But we're getting there, and we're really poised now to go into expansions. And we've had some nice little hints in particularly in renal cell, and working with the Kidney Cancer Consortium with Hans, Eric, Dan George, and others, we have their sites lined up, and so we're kind of super excited about really going after a renal cell in our expansions because we think there's a great promise there. So thank you very much. Well, I should just say, and this is I should just say, it takes a village, and this is our clinical team. So I don't want to show about that.
It is. Well, just wait. It'll pick up better for the online audience.
Fantastic. A really interesting, great novel mechanism. The first time anybody brings up gamma as a mediator of immune activity, right, I think my mind jumps to the evolving story from Andy Min's group, looking at kind of the pleiotropic effects of gamma and how it drives a multigenic resistance program to anti-PD-1. And, they just had that great paper with John Wary that came out. Have you looked at that resistance program in the tumor intrinsic methods with PTPN6, was it? Or PTPN2? Thank you. PTPN2, and do you think you're actually abrogating that program through a distinct mechanism rather than relying on checkpoints?
Yeah, that's a great question. So first of all, whenever we've used the PTPN2 inhibitor, we haven't seen like resistance. We've always seen positive activity. Having said that, obviously, some of the really clever studies that have been coming out lately in terms of, for example, even using JAK-STAT inhibitors in combination with anti-PD-1, right? That seems to be very kind of counterintuitive, right? So that's the type of thing that we that we're considering to maybe like deploy in a sequential fashion to see if we can improve things even better. But that's a great question. Yeah,
fantastic. Thank you.
Question over there.
Hi. We know about the mostly special correlation between TMB and CD8 infiltrate and how it correlates with IO response in RCC compared to other solid tumors treated with IO. Do you have any, I'm guessing at this point, mostly preclinical data about how PTPN2 correlates with TMB and CD8 or tumor-immune
meaning expression levels and
sorry?
I'm sorry, what was the exact question? Expression levels, PTPN2 or?
No, how the tumor mutational burden and the tumor infiltrate correlates with the response to PTPN2 inhibitors.
Yeah, I think in that respect, it'd probably be somewhat similar to, what you would expect from IO therapy. Having said that, one of the things we've noticed is that we can enhance expansion of clones. So whereas I wouldn't say that it'll work if there are no neoantigens, for example, mutational burden. But but what we think is it's going to be a really good way to expand the clones that are there, and in that regard, maybe take tumors that have low mutational burden and kind of boost them up to successful immunotherapy because the T cells that are there are working better. Right.
I can't remember if this was originally Nick's paper, but is this the inhibitor is a catalytic inhibitor of the PTPN enzymatic activity?
Yeah. So the drug itself, the inhibitor, is an inhibitor of the phosphatase PTPN2 and actually PTPN1, but and so it inhibits the active site of the enzyme.
Is the downstream signaling pathway that is leading to the immunological sensitization known?
Yeah. So a lot of it is JAK-STAT signaling. So as a phosphatase, it dephosphorylates many signaling pathways, and one of the major pathways is JAK-STAT signaling in response to interferon, but then also some of the other cytokine pathways. And that gets back to your question, because it's possible that some of those pathways are great and we want to enhance them, and then some of the other ones, which maybe we could inhibit with some of these JAK-STAT inhibitors, are not so good because they're upregulating bad things. And so it could be the perfect storm, that combination.
Any other questions? All right, excellent job. Cool, thanks for coming. All right, folks enjoyed David's first talk this morning so much they invited him back to give a second one. And I'm going to take the first minute of his talk to describe his title, which is uncovering the tumor-immune microenvironment determinants of immunotherapy response in renal cell carcinoma through ex vivo patient-derived models. Thank you, David, for coming.
There's a page 2, actually.
Is there page 2?
Flip it over. Yeah.
I only have one page here. But
thank you so much for the invitation to speak. And I'd like to thank KCRS, but also really the DoD, which the funding for this project, it comes exclusively from the DoD and has made this work possible. The project is in its pretty early stages. It's in our first year of grant funding. And so I want to talk actually mostly about the motivation for this, why I think we need ex vivo patient-derived models. And then we'll dive a little bit into what we've been doing. I'll also highlight that Soki Kashima, who's a postdoc in the laboratory, will be presenting a rapid oral with some more data later today. These are my disclosures. The one that's relevant here is AstraZeneca really did help to fund the initial model development. And so a lot of the early work was funded by AZ. And so I really want to start off with, why do we need patient-derived models? And I remember hearing this talk by Mark Davis, a human tumor immunologist or human immunologist in general at Stanford. And he sort of tells the joke that, if there's any mice in the audience, I have good news for you because everyone's cured mouse cancer 100 times over. And, well, that's funny. I don't actually want to undervalue everything we have today is from mouse studies, right? We have incredible detailed mechanism, and the therapeutics we have are from mouse studies. But there are limitations. And I think here's where human-based models, patient-derived models, cannot take away from mouse models, but can potentially add to it. And so I want to highlight a couple of the challenges that I think are not currently being addressed by mouse models and how I hope human-derived models might play a role. So the first is we're just very bad at predicting which patients are going to respond to which drugs. And a lot of the biomarker development that's been done has really been based on static factors. And we've been involved in this certainly as well. Things like the genotype of the tumor microenvironment, really sort of static factors, but not any dynamic responses to drugs. And so an example of just some of the challenges specifically for RCC, this is work we had done with Tony Schwery, with Savina Sereni and many others, where we looked at the genetics of the tumors treated with nivolumab in the phase 1, phase 2, and phase 3 trials that ultimately led to its approval. And we did exome sequencing and RNA sequencing and immunofluorescence and really tried to tease out what were some of the key determinants of response to immunotherapy. And I think really some of the highlights from this were negative findings. We didn't see that tumor mutation burden had really any role. This was similar to findings that David McDermott had described earlier for Emotion 150. And when we looked really across the genome, were there any mutations that really associated with response or not? We found one that was very modest, PBR1. This has been controversial and has been seen in some cohorts and not others. But I think when we look at the effect size, particularly progression-free survival benefit, if it's there, it's very, very modest. And so what we're hoping for were really the sort of EGFR of kidney cancer, that if we find this one particular mutation, it would determine a response or not. And we don't have that. We really do need tools to predict which patients are going to respond to which drugs. So that's one challenge I think we have to address as a field. The second is going from, I think, really good preclinical hypothesis generating studies to actually figuring out what are we going to bring forward to the clinic. And I'm going to highlight some of the work that we did. And again, big collaborative effort with Kathy and Tony and Sabine and many, many others. This is, I should say, not to the exclusion. Arya Kim had really outstanding work at the same time, Ellie Van Allen, Chuck Drake. But our work really looked at the tumor microenvironment, the immune microenvironment in kidney cancer. And before we even got to any therapy, we just asked a very simple question. How did that immune microenvironment change as you moved from a non-malignant kidney to early stage disease, highly curable, to locally advanced, and ultimately to metastatic disease? And this was using single-cell RNA sequencing and T-cell receptor sequencing. And we really focused on this in this first paper on the T-cell compartment and the myeloid compartment. And what we had seen was that the T-cells become progressively exhausted, so they become more dysfunctional with advancing disease stage, but that the myeloid compartment changed as well, and they became far more immune suppressive. And those weren't independent. They really seemed to be talking to one another. We could infer that from single-cell RNA-seq. So these myeloid cells were producing a lot of ligands that support T-cell inhibition, things we know about like PD-L1 and PD-L2, but certainly other things as well that support that are ligands for TIGIT or TIM3 and other factors. And that the T-cells were producing factors that then support this adverse myeloid state, things like CSF1 or MYth. And this was by transcriptomics, but we saw this at the protein level. And
with Sabina's lab, again, using immunofluorescence, seeing this in situ. But now we have this problem where we have a list of dozens of potential targets, lots of ways the myeloid cells and T cells are interacting, but we don't know what to target up front. We know that this interaction is associated with worse outcomes for patients, and we saw that in our paper, but we don't actually know which of those factors or which of those combinations of interactions we should be targeting. And I think that's really one of the challenges in moving this work forward to actually having therapeutic benefit for patients. I'll highlight another example of this that's more recent and that's not yet published. This is a collaboration led with Mike Atkins and Kathy Wu, and then in my lab by Maya Huggaboom and Lena Worth, who's here today. And that's really an analysis of now a therapeutic setting. So this is a patients treated as part of the HRNGU16260 trial. And so for our purposes, these are patients that receive single-agent anti-PD-1 therapy in the first-line setting. And we could do a combination of both bulk genomics and single-cell analysis. And I'll focus on the single-cell analysis for now. And so when we look particularly at the T-cell compartment, again, we saw heterogeneous CD4 and CD8 populations. But when we looked at if any of them are associated with altered response or resistance, there's only one population. It was a population of exhausted CD8 T cells that had a tissue residency or innate-like program and expressed this marker, SLAMF7, which we're investigating. And when we look specifically at that population, and again, for single cell, these are relatively small numbers, but we did see a pretty dramatic difference that those patients who had high levels of that population really had progressive disease and worse clinical outcomes. I said this is small numbers. We have 4 patients in progressive disease, and so we devised a gene expression signature so we could look at other bigger cohorts, including the rest of the HCRN cohort. And again, here we saw fairly large differences in terms of this signature of this T-cell population being associated with adverse outcomes. And in an external cohort in Checkmate 025, again, we saw this signature being associated with progressive disease. And so again, now we have this question. We have this really interesting population, this SLAMF7 positive, Hobbit positive CD8 population. Is that actually playing any functional role? Is that just a marker of some badness going on? Or is that really something that we might be able to actually therapeutically target and have some positive anti-tumor effect? And that's really the question that we need to answer and where we need new tools. And so I started off talking about mouse models. And again, these have been incredibly useful, but we also have to acknowledge their limitations. This is a sub-concept that I adapted from Pam Sharma's talk a few years ago at SITC, where mice are really homogeneous. They have homogeneous tumors. We often use these cell lines that we can inject. But then the hosts are also these inbred mouse strains. They're black SIGs or BALP-C. And that's really different from the patients that we see in the clinic, which are really heterogeneous in terms of the patients themselves. And obviously their tumors have tremendous heterogeneity as well. And so I think some of the difficulties in translating mouse findings to human might stem from these critical differences. For RCC, I think there have been additional challenges, and I think these are really being addressed more recently. So I think historically, for models like Renka, we'd have questions of whether these are genetically faithful to RCC, immunologically faithful, behaviorally faithful. And I think the answer for a long time has been no. But I think more recently work from Ian Frew, really outstanding work from Arya Hakimi, from Jim Bergrulas, from Gianni Genovese at MD Anderson. Really the models are getting much better. But I still think that having the human element that incorporates heterogeneity is going to be important. And so our lab has taken a couple of strategies, sort of broadly 2 strategies. One is a more reductionist approach, and the other is a little bit more of a tumor microenvironment holistic approach. And so I'll briefly step through those. The first is really a reductionist system where kidney tumors are pretty big. So we can actually take a large kidney tumor, isolate it into single cells, whether that's the immune compartment, CD45 positive, or the tumor compartment, CA9 positive, and then take those individual components and study them in some way. And we've listed a couple ways you study that so far, whether that's immunopeptidomics or transcriptomic profiling. And in some cases, this has been really challenging, but in some cases, being able to generate cell lines. So the success rate is fairly low. But now that we have the individual cell components, we can actually co-culture these very specific questions that we are asking. So we're interested in the T-cell myeloid compartment and whether those interactions are functional. We can actually just co-culture those individual cells, pharmacologically inhibit a particular interaction that we'd want, like TIGIT, and then measure what is the actual impact. What's the impact on T-cell function? Classic axes like cytokine production, proliferation, and cytotoxicity markers? And then does that actually help you to kill tumor? And so this has been our first approach. I'll spend just a second on the second part, which is actually assaying whether they're killing tumor, because this is actually difficult for T cells, because T cells, obviously, they have a T cell receptor that's specific for one antigen in a particular HLA context. And so how do we model that? And this is a system that Soki Kashima had come up with, which is used all the time in mice, but less commonly in humans, which is to use a model antigen. So just like people might use OVA or GB33 in mice, we express NY-ESO-1 in tumor cells. This is a well-defined antigen on HLA-A02, and where there's a known T cell receptor. And so after the tumor cells are engineered to express both the model antigen and some fluorescent and luminescent reporters, we can then take healthy donor T cells, which are obviously abundant, and then engineer them to express the cognate T cell receptor. And when all of those components are in place, we can see that we actually have very, very specific tumor killing. And it only happens when all of those components are in place: the right HLA, the right antigen, and the right TCR. And so with the system, now we can begin to modulate things. We can engineer the T cells to knock out things, to overexpress things. We can do so on the tumor side. We can pharmacologically add agents. And so we have a specific system to measure T cell mediated tumor killing. So that's all on the reductionist side. What about if we want to take a broader look at the microenvironment, incorporate things like the stromal component, the myeloid compartment? We're going to need something that's slightly different. And there have been a few systems that have been developed, and I think all of them have their strengths. One is from Dave Barbee's group and Rashchenkin's group. Russ now has his own group at Mass General, and this was using a microfluidic chamber with a particular size of tumor fragments, 40 to 100 microns. One comes from Calvin Kuo's group at Stanford, who's really a pioneer in organoid technology in general, an air-liquid interface system. And the final is from the NKI, from Daniela Tolman's group, which really has done outstanding work, not just in kidney cancer, but across a lot of tumor types with a tumor fragment system. But the idea, in essence, is to take chunks of fresh tumor and assay them in some way, treat them with the drug, and then be able to read something out, have some cytokine readout. We do a lot of single-cell readouts, but some sort of readout of immune cell function. And so there's a lot of systems that are available. There's other ones I haven't mentioned, like tumor slice cultures and ultra-low attachment systems. But our system is a modified version of the air-liquid interface, where we take chunks of freshly cut RCC tumor material, we embed them in a collagen matrix. It's in a little insert that's floating in media, and then we can add drug to it. And the first question is, does this actually make any sense? And Soki will, I don't want to give too much away because Soki will show most of the data, but very broadly, we think it preserves the structure of it. This is the parent tumor versus the RCC tumor. The immune cell components are preserved, and broadly, he'll show more data, but that we can actually perturb this system and kind of get results to what we might expect. And so overall, we think that this is really an opportunity. There still are challenges with the system. I think we have to acknowledge this. We're only modeling what's in the tumor microenvironment, so we're never going to be able to model what's happening, systemically with the immune system. And these are only modeling short-term changes. But I think we are able to address some key challenges. RCC has unique opportunities. Because we have lots and lots of tissue available, we can actually do this at a fairly reasonable scale and test a lot of targets at once. And so I think with the challenges, with RCC specifically, there's lots of opportunities. And so with that, tons of people to think. The organotypic model has really been led by Soki and by Ruchi Gupta, who's a graduate student in the lab, and lots of people related to the other projects as well. And thank you again to the DoD for funding this work.
So we have a couple minutes left for questions. Any questions for David? So while people think of questions, I want to sort of circle back to the HCRN paradigm here, which we have several HCRN participants on the stage here. So in that trial, you built on an IO backbone. You alter the next therapy based on response to the first one. You encouraged a biopsy at time of progression, which gets to your latest talk. I mean, this is sort of a leading question. It's not sort of, it's definitely a leading question, but should that be the paradigm for future triple development in IO? The reason I ask that question is if we heard about novel therapies today, PTPN2, NK, CAR-T, the whole thing, lots of excitement, but what I worry about, unless we change the paradigm for how we do these trials, these other interesting agents are not going to get developed in an era where we are treating patients until they're exhausted.
No, I think it's a great question. I think, and Mike could obviously speak on the design of, I think there were like really key factors there of requiring either fresh tumor material or within 1 year of really building in single cell analysis. And I think one of the big things is it was feasible. That I think there's a big concern that if you require biopsies, you're never going to be able to enroll to a trial. I think there's logistic considerations of this was a multi-center trial. Actually, it wasn't open at Dana-Farber when I was there. And so how are we going to do single cell sequencing when none of the tumor material is on site? And I think a big part of the trial showed that that's all sort of feasible. But I think conceptually, the idea of maximally learning from each trial, both on the clinical side, but then building in these analyses so that we can learn what went well and what did, and so to use that to iterate on that trial, I think I'd love if that's something that becomes standard.
I would just comment that there are opportunities to actually study these in the first line rather than the second line by adding them to standard therapies, comparing them as a benchmark to the standard therapy, the way it's being done in the Architect trial or in the other HCRN or trial involving the LAG-3 inhibitors or the consortium trial. And I think that using metastatic disease for the biomarkers is very important because the primary is not the same as the metastases, and using the right endpoints for linking those biomarkers is also important. Don't use targeted therapy endpoints to try to identify biomarkers for immune therapy. Use immune therapy endpoints. And I think we've shown that if you work in a consortium where you have access to the data and access to the tissue, you can actually do a lot of work that moves the field forward as opposed to where it's more difficult in cooperative group trials or industry-sponsored trials to have access to that between.
Great. It's a perfect note to end. We have lunch. You can still ask questions. Perfect note to end. Thank you so much to all the speakers. Congratulations to the awardees. And let's have some lunch. Thank you so much.